Thank you all for joining us tonight. We have a couple of cases that we would like to discuss that are illustrative of the things that we talked about last week in our meeting, talking about ILD that is seen in the various rheumatic diseases that we treat on a regular basis. I'm Janine Shinn. I've been working in rheumatology as a PA for about 12 years, and I'm honored to be co-presenting tonight with my friend and colleague, Jasmine. And Jasmine, go ahead and introduce yourself with your bio.
My name is Jasmine EcElhany. I've been a PA for 16 years, practiced in rheumatology for 6 years, and since 2020 have been practicing in the pulmonary space, specifically in lung transplantation. So we'll go ahead and get started. Our founding sponsors we'd like to acknowledge. And as Janine said, we're going to go through cases, really just reinforcing what we talked about last week. So I'll let Janine start with case number one.
All right, case number one. I thought RA was about joints. So tonight we're going to be looking at managing and recognizing the signs of ILD in an RA patient. So in this case, we have a gentleman who's 67 years old. His presenting complaint is increasing fatigue and shortness of breath with mild exertion, and it's been going on for about 6 months or so. He was diagnosed with seropositive RA 4 years ago. You can see his rheumatoid factor and anti-CCP titers there, and he was started on methotrexate. About 2 years ago, they added adalimumab for ongoing disease activity. So the first question that I would ask you as you look at this background of this patient is, what features in this history suggest a higher risk for ILD? Anybody who wants to unmute themselves and jump in, we have a very small group. This is casual. If you want to answer, jump in. So while we wait for someone to gather their courage, I would suggest to you that the older age of this patient, so he's 67 now, he was diagnosed 4 years ago. So he was older at onset of disease, which would be a feature that would suggest a higher risk for ILD. Also, if you remember, male sex is a risk factor. And also seropositivity is a risk factor. And then, of course, the ever contentious question of whether or not methotrexate is good or bad is thrown into this case. All right, Jasmine, let's go forward. So, primary care is the first one to see this patient, and they note inspiratory crackles on auscultation. He has normal oxygen sats at rest, but he desats when he walks. A chest x ray is ordered, and there are interstitial markings noted. He also has initial PFTs ordered with DLCO. Both of those are abnormal findings. And then an HRCT shows basal predominant reticulations with honeycombing consisting with a UIP pattern. So then this question asks us, what do the ACR Chest 2023 guidelines recommend next for suspected RA ILD? And I would say referral to Palm.
Mhm.
Mhm.
And what pulmonary would be doing, not to jump the gun, would be monitoring serial PFTs and HRCT to see if patient is developing progressive pulmonary fibrosis.
So this patient is referred to pulmonology, and they confirm the diagnosis is RA-ILD with a UIP phenotype. So this patient has now had 4 years of methotrexate. He's been on adalimumab for 2 years. He has that high titer rheumatoid factor, older age, male sex, CCP positivity. So he's considered a high risk because of those factors that we talked about. So the first question is, what baseline and follow-up assessments would you establish for this patient? And like Jasmine said, we would want them to be getting serial PFTs and HRCTs, probably the PFTs with DLCO every 3 to 6 months, depending on the availability, and also the HRCT every 12 months. And then the question that I alluded to is, should methotrexate be continued? And I think probably most pulmonologists would go ahead and stop methotrexate at this point and look for an alternative um, DMARD that would control both his lung disease and his joint disease. Okay. So here we have the treatment decision and evidence based management, which includes a therapeutic strategy to initiate the patient on an antifibrotic, nintedanib, and continue him on some low dose prednisone in the short term. Hopefully, we can taper him off with time. This pulmonologist switched him to abatacept for his RA and then stopped the methotrexate. I said the pulmonologist switched him to abatacept, but probably, hopefully, shared decision making there. And then just making sure that he's up to date on his vaccinations, talking to him about the brand new pneumococcal vaccine and making sure that he gets his boosters for influenza and COVID. And then, as we've mentioned, PFTs every 3 to 6 months and repeat that CT in 12 months. And so the question, what evidence supports antifibrotics in RA ILD? There's been a couple of trials that have been done. The InBuild trial was the one that led to the 2023 ACR guidelines, the screening guidelines, and then there have been several meta-analysis and post-marketing databases that have supported that, and then most recently the Fibroneer ILD trial, which we went through the data last week. Jasmine did a good job of going through that. So check out that talk if you weren't able to be there. What biologics might be preferred? So abatacept is a good one. Might also consider Rituxan. Sometimes we use the CD20 inhibitors. Also Actemra. So an IL-6 inhibitor. What else? Anything else, Jasmine?
Maybe tocilizumab. There's
Tocilizumab.
been some activity with that demonstrating it might be effective.
Okay. What else? Anything else? I think we can move forward on this slide. So in summary, the teaching points from this case would be to identify the high risk patient on the basis of his history profile there, the older age at onset, the seropositivity, the male sex. Those are things that we want to, keep an eye on those patients. These need to be proactively screened. We also wanna make sure that we're getting the CT and the PFTs with DLCO because you can order those by accident without the DLCO, and that plays a critical role in early identification. So even if you have normal PFTs, you could have a decreased DLCO, and that might be your first sign, or you might find something on a CT. The UIP pattern carries a poorer prognosis. And so we want to identify those patients early and get them referred to pulm because if they can get started on an antifibrotic, they can slow the decline of their lung function and hopefully preserve more of it. And as we've alluded to, cross specialty care with shared decision making is essential. So you're really going to need to collaborate with your pulmonology partners to make sure that the treatment decision is acceptable to all the parties, stopping the methotrexate, switching off the adalimumab, putting him on abatacept, all of those things would be shared decision making. Any questions about this case? If not, we'll move on. Jasmine's got the next case.
Right. So case number two, it's getting harder to breathe. We're going to focus on a progressive ILD and systemic sclerosis. So our patient is a 56-year-old Caucasian female who presents with complaints of worsening dyspnea over 6 months, as well as dry cough. And her past medical history is significant for a known diagnosis of diffuse cutaneous systemic sclerosis diagnosed 2 years prior. Physical exam is significant for skin thickening proximal to the elbows, evidence of Raynaud's, as well as a history of GERD. And her antibody profile is significant for SCL70 positivity. So, overall, what is her risk of developing ILD? It would be considered high based on her systemic sclerosis diagnosis. And because she has a positive SCL70, she would be higher risk for developing ILD. And what baseline screening would you pursue? This patient at baseline should be receiving full PFTs to include that DLCO, along with a high resolution chest CT, and considering also an echocardiogram looking for the evidence of pulmonary hypertension. So, getting more information about the ILD onset, again, she's had the worsening dyspnea over the past 6 months. She has evidence of desaturation on exertion, and her PFTs demonstrate an FVC of 71%, a DLCO of 52%, and this patient's PFTs have been trended and she's downtrending from baseline. Her high resolution chest CT demonstrates early honeycombing with the UIP pattern. So, in this patient, what are the next steps in management? And would you initiate treatment or refer to transplant? Any thoughts? So mycophenolate would be probably a good place to start. That is, it will address her disease activity both with the skin and then within the lungs. And then it probably would be wise to refer her for early consideration for a lung transplantation. And also reviewing, making sure all of her vaccines are updated and having a discussion with the patient and her family about early introduction of palliative care to help cope with that diagnosis and prognosis that she's facing. So, what role do non pharmacological interventions play here, and how would you monitor and adjust therapy? So, a few considerations for non pharmacological interventions that would be the cardiopulmonary rehabilitation that we discussed last week and helping control her breathing, helping her manage her quality of life as well, and making sure she has the tools that she needs to help manage her symptoms. And monitoring and adjusting therapy, this goes back to monitoring serial PFTs with DLCO and monitoring serial HRCTs to see if the mycophenolate in itself is enough, or if she's continuing to progress despite that, if additional antifibrotic therapy, such as nintedanib or nerandomilast, should be added on to manage that progression. So, a few pearls and teaching points in this case is really, again, recognizing high risk ILD and diffuse systemic sclerosis. Again, in my mind, the way I think of it is the more active their skin disease is, the more diffuse it is, the higher their risk is for developing ILD. And the importance of early recognition of that progressing to fibrosing ILD, which is why we monitor very closely with serial PFTs, including DLCO, as well as the HRCT, and initiating immunomodulatory therapy and having an open discussion between rheumatology and pulmonary of when to initiate antifibrotic therapy as well. And early referral to both palliative care and transplantation is key, especially in patients with systemic sclerosis, because they do progress quickly. And like Janine talked about last week, typically that progression occurs within the first 5 years of diagnosis. And so getting that early referral in really does help with their overall outcome. So, a few final thoughts and discussion. Any key takeaways that anybody had from both cases?
The
Uh,
quiet group.
it's very quiet. I won't call out names. And how has this shaped your ILD suspicion and management framework? Maybe I'll just pose the questions to Janine. And what part of the diagnostic or treatment timeline do you feel most confident in or least confident in?
I know I feel the least confident in the referral to lung transplant. I feel like that's a really big step. That makes me very nervous.
Yeah.
That conversation is hard, you know, all of those things. And I kind of want to punt that to pulmonology and say, well, let's, when your pulmonologist feels like you're ready, but I'm not sure
Yeah.
if they are always doing that. And
Yeah.
especially bringing up the conversation about palliative care.
Yeah, I can see that standpoint, especially from a rheumatologist point of view. If you don't want to jump the gun when pulmonary hasn't recommended that. And I think that's really key when you're having those discussions directly with the pulmonologist. If you have somebody's number or name that you can pick up and call, because it's harder when you're trying to find out information from the patient for sure.
Yeah.
I think that is the end of our presentation. Appreciate everyone's time. Any questions anyone has?
I think both of us have our information on the ILD Community Network website. So if you think of any questions afterwards, you can shoot them to either Jasmine or to me.
Right. Well, thank you all very much.